Let's get started. So, who is this guy? I'm a husband of an amazing wife named Lori. I've got 4 boys. I am a pilot. I'm passionate about piloting. I fly a fixed-wing little airplane. I also fly little powered paragliders. So I'm kind of all over the board. I have passions for for the world poor. This leads me on mission trips around, usually yearly, around the country, around the world, where I go, and sometimes I do medicine, sometimes I do other things to different countries. And I've been in town for 23 years. I'm an orthopedic surgeon by trade. I'm in the business of pain and its relief, and that makes me a prescriber of opioids. But this pedigree doesn't mean that much to me. One thing you need to know about me is I'm a man of deep faith in God. And so I tell you this not because I want you to think a certain way about me, just so you understand the perspective from which I speak. When Kurt asked me to talk, I said, "All right, God, I'll see what I can do to kind of enlighten folks." It turns out that as it is, I'm pretty certain that God gave me this opportunity basically to educate me rather than educating you. So I appreciate this chance to have you guys listen. And from my perspective, in my past, certainly I've been a heavy prescriber of opioids, and I've changed a lot over the course of the past 23 years, partly because surgery's improved and we haven't had to use as much opioids. And the truth is, people are doing a lot better because we're not using a lot of opioids as well as we have been, at least. And since I've taken this task up, certainly my prescribing has changed in the past few weeks, and I anticipate it to continue along those lines. So first, a disclaimer: a lot of what you'll see in terms of statistics in some of these studies, I'm quoting others. They're not my original studies. Dr. Teeter and Dr. Finn are both guys who bang this drum, and you'll see a lot of statistics on the screen. If you want the full disclosure, I can give you all my list, but basically none of it's mine. We're in a current state of opioid epidemic. Obviously, from all your backgrounds, you guys are getting experience in that realm. We're going to talk a few numbers here. 2016 numbers: 116 people died a day for the year. That adds up to about 42,000. The next year, depending upon how you count it, it went up 16%. So we're not making any great strides in this. So 50,000 people a year. If you equate that, if you remember back when we had the 9/11 tragedy, we lost 2,900 people, most of them in their highly productive age, 25 to 50-year-old age range. If you equate that to the heroin and opioid epidemic, that's happening every 3 weeks, and I marvel at the death toll of this epidemic. We had lots of press, and the whole world was up in arms over the 3,000 people we lost 18 years ago. Not that was anything slight, but we're doing that every 3 weeks now. 11 million people misused opioids this past year, and 2 million of them were brand new misusers. So you can read that as 8 million of them are either taking way more than they're supposed to, they write prescriptions, they buy it on the street, and the other 2 million just started doing that. And if you compare it to heroin, we also had 1 million people use heroin last year, with roughly a fifth of that starting for the first time. And the reason the first-time users are important is because the life expectancy of these people aren't forever. If you think about it, how long do you think an active heroin user lives from the time they start till the time they die? What's the average life expectancy? Anybody got a guess?
4 years.
4 years is dead on. So you read the book. 4 years is when 50% of them from the time of first heroin use is when they die. And so they don't all die, but a few of them die that first year. And there's a lot of mixing with heroin and opioids, so I'm going to kind of, so some of the numbers are, they're not many people die from fentanyl and heroin use combined. So some of the numbers kind of cross over each other, but it's crazy world out there, and once they're caught, it's really a tough one to beat. The average, if they're in a medical management program, I think about a 68 or a 69-year-old fellow who's actively, taking methadone every day, and so they can be managed and have a good life and productive life if they're in a program to kind of curb their cravings. The statistic here is that they're 4 times less likely to die if they're in an aggressive program. Here's a slide that just depicts the growth of heroin and opioid problem over the course of the past, 13 years. I found this slide to be, I would say, really busy but really interesting. Let's see if I can blow that up. So if you look at it, 2011, other than morphine, other than the green line, I think things looked pretty good. All of the numbers were down under the 5,000 level. Around 2007 is when there was a huge spike in pain clinics around the country, and that caused people to get huge amounts of narcotics, and they diverted them all around the country. And you can just see, 2011, that's 7 years ago. It wasn't very long ago. You look at the vertical line of the synthetic opioid deaths, and all of them, even the meth, even the cocaine, all of them are just cruising up in just huge logarithmic numbers. So you can see there, we're going to define a few things later about the difference between opioids and heroin, natural and synthetic, but those are all additive. So you get 30,000 for the synthetics, 15,000 for heroin, and another 14,000 for the hydrocodone, oxycodone, those overdose deaths. So it's truly an epidemic. Let's see if I can undo what I did. Maybe I cannot. All right. So I found this slide to be really interesting too, especially if you're a first responder. I'm going to blow it up a little bit. If you look at this, this is a slide that represents ambulance trips that use Narcan. So the dark brown are the high incidence, the light are the low incidence. But if you look at Wood County, or we're kind of in the middle, I was amazed at some of the counties up north, the Oneida and Forest and Vilas County, counties that I think are pretty not very populated, super heavy use of heroin and lots of overdoses there. So this slide doesn't talk about law enforcement using it. It's only ambulance trips, and it's just a representative. I expected it all around Milwaukee. Well, it's all over the state, and even the rural parts are sometimes even worse per capita. So some of my real life experience I've seen, so heroin addicts or opioid addicts tend to come to me when they have infections. I've seen bad infections in the arm, such that the arm, I remember taking one guy to the operating room over 20 times for his arm infections. Turns out that guy ended up in Madison and he lost his arm. I've taken people, one of the addicts didn't have any veins left, and one of our nurse anesthetists found a vein in the chest wall, and then sure enough, 6 months later, that guy is back in the operating room with a bunch of chest wall infections because he learned where other veins were on his body, and when it's just amazing. I put this next slide in there because from my personal experience, it's been a little bit interesting. I don't see tons of 25-year-old men who have these infections. I see a few. What's come to me, I've seen a lot of women. I've seen women who are not 17. I see them when they're 30 or 40 or 50. And some of them are in their childbearing years. Several of them, have had many children, maybe 4 or 5 kids. And 2 in particular, I just say this because it gives me insight into the disease. 2 of the women gave away their kids, gave them to the state, gave them up as wards of the state. And at first I was, appalled, and they were sort of proud of it. And then I thought about it, and I thought, well, maybe that's kind of good. It keeps them out of this dysfunctional kind of lifestyle. But if you really think about it, what makes a woman give up her kids? The power of this addiction must be so impressive to something that's so inherent to, I don't know, the depth of our soul. You would never give up your kids. If you're a mom, I just can't, I can't think of it as a dad, and I see the moms out there, if they're willing to give it up, it just must have unbearable power. This is another personal experience. This is an evidence of what happens to things that are injected. So you think about what an opioid user does. They first start taking pills. Once they start taking pills, they meet other people who are taking pills and using heroin, and they realize that you can cut up pills and inject them and get a better high. So if you think about what are in pills, many times you'll have a pill that has 10 milligrams of the active substance in it. Another time you'll have one with 650 milligrams, and they're all the same size, or you realize that the drug companies put in fillers in pills, and it's totally okay to do, because it makes the pill easier to take. Sometimes it slows down the absorption. It's good things. But the things they put in pills for fillers are toxic to the inside of us, but not when you eat them. So there's talcum powder. That's a real common filler. Silicone, sand, and methyl cellulose, things that are ground up wheat. They put that in a pill, and when you eat it, no big deal. If it's sand, it just goes out the other end. If it's wheat, you absorb it, and it's a teeny bit of carbs. But the thing is, if you cut this up and put some water on it and inject it into your veins, your bloodstream is not designed to see sand floating around in it. The sand and the wheat germ go into different spaces. Here's a sad case of a woman who was caught in this addiction, and on your left is a slide of her spine when it was okay. They were looking for a blood clot in her lung, and this is a CT scan. And this is her about a year and a half later, after an untreated and unrecognized infection from the fillers of the pills lodged into her spine. It just melted away her bones and the discs. And so here's a pretty young woman walking around like the humpback of Notre Dame with severe pain in her back from this kind of indolent chronic infections just eating her up. It's kind of like cancer that you put in there yourself. So let's talk about addiction. Addiction used to be something that people thought of as a lack of willpower or a moral failure, but now it's really a disease of the brain, and it's recognized that it's chronic and relapsing. It gets influenced by a lot of things. Women get addicted faster than men, but women don't take nearly as much drugs as men. Why that is, we don't know. It's influenced by a lot of who your parents are, your psychological state, a lot of environmental factors, and so some people don't get addicted right away. Sometimes it can be a week and you're addicted. And so it's a very variable phenomenon. It can, in the drug addict, it's characterized by loss of control, even though you know that you're harming yourself or you have consequences that are harmful, and it's also associated with an intolerable craving for the drug. So opioid addiction is also unfair. It uses our own body's hormones against us. We have endorphins, the opioid of the brain, and when you take short-acting opioids, it tricks the brain into thinking that that's our natural endorphins. And once you have a kind of a steady state of it, your brain quickly becomes used to having that, and it thinks it's biologically essential. Once it's deprived of that, then it starts going into withdrawal. So it causes this dysfunction, both emotionally and physically. So you get shakes, you get cramping, you get pain. It makes all your pain receptors hurt even when you're not in pain. So it causes this brain dysfunction. And the problem is, even if you're able to achieve abstinence, even if you're able to achieve, people who can get off the drug, their brain tells them the lies that it needs these things for years, sometimes 10 years. That's why the relapse rate is so high. So how did we get here? Back in the 90s, the pharmaceutical companies were on a big marketing campaign telling all the doctors that if they're in pain, they won't get addicted. But what I said the other night, and I believe this, I don't think that the doctors really believed this, that they couldn't get addicted. We were taught that these were addictive medicines, and I think that a few things. I think that the doctors really didn't care that much about it. I think that, in all honesty, they thought they would get addicted, but it maybe wasn't a big deal, and then they just get off the medicines. And certainly that's been a little bit of my mantra. You know, people who have a femur fracture, you know, they're going to take medicines for a few weeks or a few months, and maybe they get a little addicted, and we'll just get them off of it, and it's no big deal. Truth is, we weren't really educated about the true dangers of drug diversion and how people can get caught with this. And so it's not that the drug companies are so evil, but they did market their new drugs pretty hard. There was a rampant increase in pain clinics, and I tell you, the easiest way to treat pain is to just write large prescriptions for narcotics, and people are happy, the doctors are happy, they go away, and it seems all good for a while. And so an easy solution to the problem was sold, and we bought it. And what we found out is that opioids, they treat emotional pain really, really well. You can take narcotics if you're depressed, and you feel much, much better. If you think about the opium wars, they were not fought over people who wanted to get out of pain. They were fought because they liked how it made their brains feel. Another thing that was developed in the late 80s and early 90s was the WHO pain letter, the World Health Organization. It's basically a way to treat cancer pain, but it's kind of a mantra that was taught to all the medical students that you can start with anti-inflammatory agents, but as soon as pain gets bad at all, you want to get to the narcotics. And it basically just solidified that, you know, the narcotics were the best pain relievers out there. So what can we do about this? So first of all, culture has to change. You guys are probably the people who have already changed your culture, and so you don't need that as a lecture. But we need to change the idea of what's good and what's bad out there. Medical prescribing regulations have changed quite a bit, and certainly in this state, and there's a lot more regulation. We can find out who's getting what drugs from other providers, and we even have to go onto the website and find out, check out the patients to whom we are prescribing the medicines to see if they're getting it from others. We should have community discussions. We should all get educated, and certainly there should be a lot more education to the medical providers, kind of changing the flow of the idea of what's effective. So this, I'd say it's imperative for our communities, and it protects all of us. So let's talk about the effectiveness for a little bit. The effectiveness of opioids in treating musculoskeletal pain, they certainly have been used for thousands of years. Everybody thinks that they're the best thing out there, but there's a lot of new evidence that would refute this. It won't refute that it treats the mental anguish of pain, because it does that really, really well. But you're going to find out that it's not the best peripheral pain medicine. So opium is the plant from which morphine and codeine are derived. So I'm going to talk a little definition here. Morphine, codeine, and thebaine are 3 of the 20 alkaloids that are available in opium. They are called opiates. So Dilaudid is not an opiate, it is an opioid. So opioids are everything else that are made from morphine or codeine. So they're synthetic and non-synthetic, or they're semi-synthetic, and there are synthetic opioids. The semi-synthetic are made from codeine or morphine, like hydrocodone or oxycodone or hydromorphone. And then there's the purely synthetic ones, including the new super strong one that just came out. So tramadol is a synthetic one. It's the weakest synthetic, and fentanyl was the strongest synthetic, and now there's a couple more that are even more potent. But it was interesting thing about tramadol. It came out in 1999. It was classified for 15 years as a non-narcotic. Truth is, all of us knew that it was a light narcotic, where we just thought it had very low addictive potential. Truth is, tramadol has a lot of addictive potential. It's not that good of a pain medicine, but you can get addicted to it, and it's even not that good. So it's not just the pain relieving effects to which you get addicted. It's something else that happens in the brain. So a little bit about history. So for a couple thousand years, you had only morphine to treat, or opium to treat pain. Then in 1900, Bayer developed aspirin, really good medicine. It became the standard of a non-steroidal anti-inflammatory medicine. So it's not cortisone or not hormone-based anti-inflammatory. So you had that for 50 years until 1950 when Tylenol came out. And then in the early 60s, there was probably 20 or so anti-inflammatories that came out, and since then there's maybe been 10 more. So there's the two main groups, the anti-inflammatories, of which aspirin and ibuprofen are a type, and then there's Tylenol, which is a non-anti-inflammatory agent. The Tylenol is good for pain relief in that it doesn't bother your stomach, but purely inflammatory pain is not that good for. So you'll see that the anti-inflammatories are tougher on the kidneys, and the Tylenol is a little tougher on the liver. Truth is, both of them are sort of the over-marketed. I would say the risks of these medicines, unless you're taking them continually and at high doses, they're both extremely safe medicines. Certainly Tylenol has been. Tylenol is only unsafe when you take more than 20 pills a day. So doctors prescribe because they think that things work or don't work based on their perception. And certainly their perception is that narcotics have been the best. But there's been a couple of new big studies done by people who are not owned by the drug companies. So there's a couple of agencies out there that are non-profit, funded by governments, and they do their own research, and they don't get any money from Merck, Sharp and Dohme or Dow. And so I'm going to quote a few things to you. Some of them are technical. Some of us might make sense to you easily, some might not, but it'll become clear later. There's something called the number that's needed to treat. So if a medicine is 100% effective, its number needed to treat, or NNT, is 1. And so a good oral pain medicine the number is 2.5, is a good oral pain medicine. So what that means is that you have to treat 2.5 people for it to be 50% effective. So a poor medicine would be one that with a number of 10. So you have to treat 10 people before you get actual relief of 1. And so for oral pain medicines, a really, really good one is 1.5. A pretty good one is 2.5. So here's a couple of studies that were done. Medicine that I used to use a lot of, oxycodone, in the form of Percocet. 15 milligrams of oxycodone to me is a pretty darn high dose, and it gives you a number needed to treat of 4.6. You almost have to treat 5 people to have 50% relief of their pain. And to me, that's lousy, and that's surprising. But it's not surprising that you look at the next one, the oxycodone 10, and I think that's 650. So that's 2 Percocets, gets you into the good range, 2.7. But what is surprising is that 2 Aleve or a 500 milligram naproxen in a double-blinded, random, prospective study where no one else is paying for it, they say that it's the equal pain relief from prescription strength Aleve compared to 2 Percocets. That to me is eye-opening, and it's even more so when you take a weenie dose of ibuprofen and you put it with Tylenol, and you get an even better relief of pain when you combine the Tylenol and the ibuprofen in it. So that was done with a Cochrane study. That's a large group in Europe. This is a different study, Bandolier, where they came up with very similar results. I happen to use diclofenac. I like that a lot. It was fun that turned out to be their best medicine against pain. And if you look midway down or even further down, there you have Percocet, oxycodone 10s plus 1,000 of Tylenol, you get 2.7. I'm suspicious that the Tylenol addition is the thing that really makes it good. And further down, pure morphine, even worse than that. And so the idea the way they question these folks is that they'll have a broken femur. They'll give them, Aleve, and they'll ask their pain. They'll say what their number is. Now the folks who get Percocets or the folks who get morphine, they may not care as much. They may enjoy it, but they'll tell them that the number is the same or not as good as if they get an anti-inflammatory agent and Tylenol. You notice tramadol's down at the bottom of this, yet it's still very addictive, but the true pain relief function of tramadol is pretty poor. Now, there's all sorts of kinds of pain, and so there's the kind of pain the kind of pain on the right certainly needs a whole bunch of narcotics, because what you want to do is disassociate the mental stress of pain from what's going on. And then there's the other kind of pain, which just needs a little ice bag and a hug. So that was my son, by the way. So no HIPAA violation. So there's acute pain, there's chronic pain, there's all kinds. There's neuropathic pain. They're treated very differently as you get into it. Some is long, some is short. Some is cancer pain. There's shingle pain. There's a lot of different pain that people describe. I personally think that sickle cell pain or potentially renal kidney stone pain, to me, seems like it's more severe than a broken pelvis or a broken femur. I get to see a lot of bone pain. It's not severe. It's severe, but it's maybe not the most severe pain out there. Certainly, the most mentally wearing is the chronic pain. So, some of the conclusions of their studies. I just want to, that the gold standard should be a good anti-inflammatory agent and a whole bunch of Tylenol early on. And if that fails, or when that fails in the acute phase of things, adding short-acting opioids, and then soon thereafter, after the surgery, after the acute phenomenon, trying to wean from the short-acting opioids quite soon after that. We're going to get into some chronic avenues where they use a lot of alternatives, and I'm going to go over those. But highly minimizing opioids is going to be the mantra from here on out. All of this has got a caveat that you should check for pre-existing liver or ulcer disease, as well as blood thinners and other things that can change how you're going to prescribe. So in terms of alternative prescribing options, which is part of the title of this, I want to kind of dive into this just to kind of be clear that there's a lot of different alternatives that we use, and probably one of the most common ones are antidepressants. So there's several groups of antidepressants. The studies show that the tricyclic antidepressants tend to be the most effective in helping treat pain, because pain certainly has a mental capacity to this. And I see people with all sorts of acute issues. Some of the acute issues I bring on when I do surgery on people, I'd say I have about a 40% depression rate in women 3 weeks after a knee replacement, and almost a 60% depression rate in men. A lot of times that's just evidenced in, disturbed sleep patterns or crabbiness to their husband or wife. And so it's not entirely, major depressive, but clearly signs of depression. And not everybody uses, nor do I use antidepressants for the people who have, I'll say, acute or situational depression, because at 4 weeks or 5 weeks, boy, the lights are brighter and everything's better. I tend to warn them that half of the people are going to get depressed, and what I'm trying to avoid now is not covering that depression with opioids, because that's historically what I've done. And if they do have depression, tricyclics are the best thing for it. They're most effective. However, when women find out that it comes with some associated weight gain, that's usually off the table. So there's a few other classes, the SSRIs and NRIs, that help with pain as well. One of them, bupropion, is associated with a little bit of weight loss, so that's usually a more popular one. And actually, it's medium effective for helping curb some pain, and certainly curb some of the mental effects. But basically, in my experience, those four, bupropion and Cymbalta, are probably the two that are I've seen it make a big dent. And usually it's just a couple, 3 weeks of it, and for the acute pain. And others, for folks who have chronic long-term fibromyalgia kind of pain, definitely I would like to see them on Wellbutrin or Cymbalta. There's also been a new move, I'd say that's probably in the past 10 years, of using anticonvulsants. And this is from a medical pharmacological geek kind of perspective. It's neat how this works. So anticonvulsants are seizure medicines that keep your brain from having a seizure. You think of it, the brain is the biggest nerve we have, and anticonvulsants work by calming or settling down the electrical impulses that the brain has. So in small doses, anticonvulsants subdue the peripheral nerves, and they make the nerves still feel the same way, but when they're over-agitated and they feel buzzing, tingling, burning pain all the time, taking a little bit of an anticonvulsant, certainly gabapentin, tends to decrease neuropathic pain very, very well. Not everybody can take it. It has some side effects that some people can't tolerate, but usually if you introduce it slowly, you can have someone on some gabapentin and, up it a little bit every week, and they don't notice the side effects. The side effects of them are usually sedation and sometimes a little mental fogginess. So usually if you back it off or leave it a little while, the side effects go away. Yes? Yeah, it's interesting because they're using it for depression, and if you take a lot of it, you get high. It's a dopaminergic blocker, and so if you take a lot of gabapentin at once, you can OD on it. A couple people have died, and you can overtake it and have it be a euphoric stimulant. With gabapentin, I don't know of any other routes besides oral that they take it, but if you were to inject it, I don't know.
It was, in the recent past, it was prescribed an awful lot inside of jails, and it's scaling that back. So
I think it's just that. I think if you hoard it and take 8 pills, and then you get a euphoric feeling, and that's what I know about it. And it's not controlled like morphine is at all, but they do keep track of it now, and so I believe that there's a weak area for abuse. Mm-hmm.
Is gabapentin UA detectable?
Yes, you can see that as well. And I would say it's nothing like, I use it in people who are opioid dependent. I think it's a great medicine that's not very addictive. So I would say it's super, super low compared to a narcotic. So
It's abusable.
abusable, yes, it's abusable. I can think of one person in my practice who seeks it for that sort of effect, but it's a microcosm of the rest of it. So another area, muscle relaxants. This too is not very well regulated. The government would like us to prescribe cyclobenzaprine. My experience with that is it's pretty weak, but it's effective for people who have back pain. The one that they don't like me to prescribe, and it's my favorite, is carisoprodol. So all 4 of them are centrally acting muscle relaxant, and so my favorite one is the last one. It does give you 5 minutes or so of euphoria, slightly, but it really takes the spasm out. And so from an effective standpoint, it's a great medicine, and I caution people not to drive on it, at least not for the first time they take it. Most of the time, these people are laying in bed and trying not to go to the emergency room. So I think I think they'll be also regulated a little more in the future, just because they probably have some potential for abuse, but I don't think it's very high. So anxiolytics, fancy word that basically are things that you can read here. They're calming agents, they're sedatives, and they kind of interrupt the anxiety associated with things. And the problem with pain is that a lot of times pain is associated with depression, and depression and anxiety are soulmates. And so trying to break the anxiety is important. And the problem with these is that now we've made a few strides in 2018. We've backed down some of the opioid deaths, except the benzodiazepines, which is this class of medicines, when you combine them with opioids, it suppresses respiratory depression you have a lot more respiratory depression with it, and there's actually the deaths from opioids and benzodiazepines are up in 2018. So people are maybe using more Xanax or lorazepam instead of opioids, and some people are abusing them and dying. So it's a lethal combination. So medical marijuana, obviously a big hot topic in our polls for the past week. It's by definition a very dangerous medicine. The idea of using medical marijuana for pain control is almost always over-marketed. There are a few people, a couple epileptics, and a couple people who absolutely need it. The idea that medical marijuana helps with pain control is a farce. It's one of the worst pain medicines out there, but it seems compassionate when people have cancer and you want to do anything for them. You want to vote for using medical marijuana to help people with cancer get out of pain. Truth is, it's not a bad reason to use it for people with cancer, but just not to treat pain. The problem with having it available for medical marijuana is it can be completely abused and prescribed for pain for the average 25 and 30-year-old, and it does not work at all for that. It's definitely an entry-level drug to other medicines. It is not a substitutionary drug, which is what they thought. They might be able to get people off heroin by just getting them to be addicted to marijuana. And it turns out that it's just a companion drug. They use them together, and there's been no decrease in heroin use because there's been availability of marijuana. Colorado proves that. They have had the country's longest medical marijuana program, and they've had their highest heroin abuse rates in the past year. So it's not, a lot of states are going to it, and I would bet that we will as well. And it will only worsen our drug phenomenon. Marijuana is proven to make you lazy and mellow and feel good and hungry. It's not been proven to treat pain at all. So non-prescription alternatives, so things like chiropractics or different things. My favorite one, I got to tell you, is surgery. If you have back pain, there's a lot of things we can do with surgery. On this slide are a list of a lot of different things. Radiofrequency ablation, kind of fancy word. You see some pain clinics that do this. They burn little nerves, and we have got a slide on that. A few things that I don't talk a lot more about, but came up at the other talk was nerve stimulators, electrical nerve stimulators. You can have them that are on the skin. We call them TENS units, transcutaneous electrical nerve stimulation. You can buy them at Shopko now with battery packs. They actually work pretty well. It's just that they're not as easy as a pill, but they do help local pain. There's also the implantable ones. The implantable ones are fraught with problems, infection, and lack of efficacy, but there are a few people who continue to use them. They are not paid for by insurances typically, and they are extremely expensive. We had a fellow the other night that said his nerve stimulator in 2003, which he didn't pay for, was the whole price was $188,000 for the implantation. So, yeah, there you go. There you go. I remember the number. But some people use them and are, it's effective for them. It's hard to know who's going to be effective. So if you've got worn out knees, don't take narcotics for them. Get surgery. If you've got spinal stenosis, there's great fixes for these that only require narcotics for a week and tend to have quite good outcomes. In terms of radiofrequency ablation, when you can find a specific nerve, sensory nerve, that is causing you pain, it's possible to isolate that nerve and burn it and break up the signals of the pain generation. Generally, when you'll need narcotics to recover from the burned nerve feeling for a while, and that sometimes leads to problems, especially in pain clinics where they do nerve burnings every 6 months because they grow back. And what we know from medicine is that they don't really grow back, but they're not probably gone. So they still give you some pain, but they do seem to modulate your pain. So there's some improvement or some areas that might be of benefit around a worn-out knee or around certain specific areas. If you can isolate that area, potentially you can improve their pain by damaging the nerve through burning it. But it's very controversial, and I've seen this concept abused highly. In fact, I have several patients. I have one patient who I like to find out how much they spent. This fellow spent $81,000 on injections at a pain clinic out of his pocket. And, you know, rampant injections and rampant radio frequency ablations, they are negligence and shouldn't be tolerated. So here's back to the manipulation in terms of chiropractics and massage. I think all those things have their place. They do a great job of doing, you know, local spasm control. Problem is that they're oftentimes used for lots of other things, you know, blood pressure control, headache, lots of things. I think they're great for focal or identified problems. There's also a whole area of things about which I am not an expert, and essential oils, if they make you feel great, I think that's more power to you. In general, if something doesn't cost you too much and there's not a lot of side effects, I think trying acupuncture and anything else is certainly okay. So in summary, I would say that pain, from a culture perspective, we should learn that it's not the worst thing in the world. I left something off of in my talk earlier. That's part of our problem, is that pain has become, being pain-free is turned into a right, and no one promised us that we'd be pain-free, but if we try to be pain-free pharmaceutically, we have all these other problems. So I would say public enemy number one is not pain, but opioids may be. We should, you can treat the mental stress of pain for short periods of time with opioids, but then that can't be part of the chronic treatment. Otherwise, it changes the people's brains permanently. And if you, as a provider, as a medical prescriber, we need to know that we're damaging these people for years or potentially indefinitely if we take that route. And we have to weigh the benefits, and almost never are the benefits of that outweighing the risks, because the risks to the patient and to their family members and the community are great. Opioids are not the best pain relievers, but Tylenol and anti-inflammatory agents are, and they're almost always the most safe to prescribe. And the consequences of over-prescribing opioids are wide-ranging, and this has been eye-opening to me, that, you know, potentially that I've been part of the problem even in this community. I'm trying to undo that. So pain management clinics, there are dangerous places. They may be okay for a few people and for certain kinds of therapies, such as, you know, radiofrequency ablation perhaps, or maybe a nerve stimulator, but they should be heavily watched. And every addict in our community should have access and brought into a medical management center so that so they can live longer and live productive lives. And that, I think, culture change is definitely a really important part of this, and you guys are part of the change in the culture, and that ultimately opioid prescribing absolutely has to be curbed. And this is probably the best way to get high, either on a mountain or in the air. So thanks for your attention.